Bonjour, je m'appelle Anne Lagacé Dowson de la Coalition canadienne de la santé, fondée en 1979 par, entre autres, Tommy Douglas pour protéger et faire avancer l'assurance maladie pour tous et toutes. Today we're here with public healthcare leaders and a legal expert with a new legal opinion on Bill 11 in Alberta. We're also here to ask the Federal Minister of Health, Marjorie Michel, to enforce the Canada Health Act and play the role that is designated to the federal government. We're also releasing a legal opinion prepared by lawyer Emma Phillips of Goldblatt in Toronto. Nous sommes là pour faire appel à la ministre de la Santé, Marjorie Michel, de faire respecter la loi canadienne sur la santé. Et nous sommes là aussi pour rendre publique une opinion légale qui, on espère, va changer le débat sur la question du rôle du fédéral en ce qui a trait à la loi 11 en Alberta. So our first speaker is Jason McLean, who is the chairperson of the Canadian Health Coalition. And after Jason, Emma Phillips, the lawyer for Goldblatt, will speak, followed by Chris Gallaway of the Friends of Medicare, and Melanie Bechard, Dr. Melanie Bechard, who is a pediatric ER doctor at the CHIO here in Ottawa. Thank you. So over to you, Emma. Oh, sorry. Pardon me. Over to Jason. Pardon me.
Good morning. My name is Jason McLean, and I'm the chair of the Canadian Health Coalition. The CHC was founded in 1979 to do exactly what we're doing today. That's to defend universal public health care from those who would undermine it for personal and corporate gain. Today, we make public a new legal opinion that we commissioned. Our lawyer, Emma Phillips, will present in detail in a few moments. We wanted a legal opinion because we wanted proof of what we already know, that Bill 11 is a threat to the well-being of Albertans and Canadians. On December 18th, in 2025, during the pre-Christmas rush, the United Conservative Party pushed Bill 11 through the provincial legislature. Debate on a complicated 296-page bill lasted less than 4 hours. There was no input from citizens or those who work in the healthcare system. The Alberta Medical Association, representing Alberta's doctors, told journalists that it was completely in the dark about Bill 11. Bill 11 is a product of some sort of partnership between private insurance companies and the elected members of the Smith government. Private health insurance giants, Manulife, Canada Life, Sun Life, who control 63% of Canada's $64 billion life and health insurance market through workplace plans, were front and center in getting it through. The Smith government even created a 24-member working group of industry representatives to oversee Bill 11. Private insurance loves privatization. The president and CEO of the Canadian Life and Health Insurance Association, the CLHIA, Stephen Frank, said during a February 2023 webinar on industry trends, the crisis in healthcare is an opportunity for us to do better for Canadians, to do better for patients. But let's be honest, with this being for profit, to also do better for themselves. Think about it. These hugely profitable companies see the crisis in healthcare as an opportunity to make more money for themselves and their shareholders. Publicly insured healthcare is just an untapped market to break into now that the system is in crisis. And that crisis is being fed by provincial governments like Danielle Smith's. With the Ontario government's Doug Ford and the Quebec government of François Legault and the Saskatchewan government of Scott Moe. But popular resistance to this unprecedented attack on public health care is already gathering steam. On March 16th, the Canadian Health Coalition and provincial health coalitions organized a day of action to break the silence on Alberta's two-tiered health care and to call on the federal government to enforce the Canada Health Act. Some members of the federal Liberal caucus spoke out against Bill 11 in response to the day of action, including Vancouver MP and Dr. Eddie Fry. Fry said there is no doubt that Alberta's Bill 11 absolutely contravenes the Canada Health Act. She has since been removed from the position of chair of the House of Commons Health Committee. Health Minister Marjorie Michel has repeatedly said she is the guardian of the Canada Health Act. Today we're calling on Minister Michel to use her powers to clearly state that Bill 11 contravenes the Canada Health Act and to intervene to protect Albertans and Canadians from the misguidance of the Smith government and the greed of the insurance industry. Public universal health care defines Canada in the face of attacks from the US. It saves employers money and it protects the health of Canadians. I'm going to close with a quote. We as a society are aware of the trauma of illness, the pain of surgery, the slow decline of death are burdens enough for the human being to bear without the added burden of medical or hospital bills, penalizing patients at the moment of vulnerability. And that is from former Supreme Court Justice Emmett Hall in 1979. Folks, time is of the essence. The federal government needs to do its job and to protect the health of Canadians by upholding and utilizing provisions within the Canada Health Act. Thank you for your time.
Good morning. Bill 11 not only allows for, but entrenches a two-tier system where those with the means to pay can access medically necessary services faster than those who depend on the public care system. By allowing physicians to simultaneously work in the publicly funded healthcare system and to charge private fees for medical services, Bill 11 fundamentally violates the key principles of the Canada Health Act, that is universality, accessibility, and comprehensiveness. And these principles are conditions for the federal healthcare transfer payments to the provinces. Fundamentally, a healthcare system that lets some people buy faster access to medically necessary care does not comply with the core principle of the Canada Health Act, which is that decisions about the provision of services should be made on the basis of medical need and not on the ability to pay. So in practical terms, Bill 11 means that an Albertan visiting a surgeon for a hip replacement could be told that they could have their surgery at no cost in the public system in, say, 8 months, or that they could have the same surgery with the very same surgeon, but much sooner if they pay for it out of their own pocket. And it also means that some Albertans will be charged fees over and above what is already provided under the public insurance system, despite the fact that this form of user fees and extra billing is strictly prohibited by the Canada Health Act. The system that Bill 11 allows, what's euphemistically referred to as a dual practice system, has never been permitted in any other jurisdiction in Canada. Contrary to the assertions of the Alberta government, dual practice is not permitted in New Brunswick or in Quebec. And that's because dual practice is fundamentally contrary to the promise of the Canada Health Act that all Canadians will have access to medically necessary health services on the same uniform terms, regardless of their financial means. Bill 11 doesn't introduce new resources or make the system more efficient. It allows certain people to move to the front of the line based on their ability to pay. And what's particularly important to underscore is that the federal government has already and repeatedly taken the position that precisely this kind of dual practice violates the Canada Health Act. So the jury is not out on this question. In its legally binding interpretation letters and in formal legal positions taken before courts, particularly in the Canby trial in 2020, multiple federal ministers of health have concluded that dual practice, precisely of the kind introduced by Bill 11, contravenes the Canada Health Act. And that was because, as the evidence in the Canby case clearly showed, the experience of numerous jurisdictions internationally is that dual practice shifts our limited medical resources, that is doctors' time and operating room availability, into the private pay market. It incentivizes doctors to stream patients into their pay-for-service practice and creates conflicts of interest for doctors. The results, as the federal government itself argued and as the courts found in Canby, are likely to be longer wait times and poorer health outcomes for those who do not have the ability to pay. In fact, the judge in Canby found that dual practice primarily benefits the affluent and healthy and will likely exacerbate health and wealth inequality. So the question has to be asked, who benefits from Bill 11? Certainly not the majority of Albertans who depend on the public healthcare system and who, contrary to the government of Alberta's claims, are likely to experience longer wait times as a result of this new legislation. The whole structure of Bill 11 is premised on queue jumping and unequal access to medical care in contravention of the Canada Health Act. And again, the federal government has effectively already found that Bill 11 violates these core principles of the Canada Health Act. That really isn't in question. The real question is whether the federal government will now take the steps that are mandated by the Canada Health Act where a province is in violation of the Act, and that is to deduct cash transfer payments to the violating province, in this case, Alberta. There has been some suggestion that the federal government needs to wait and to review the regulations to the legislation. And frankly, that is sidestepping the issue. The fundamental problem created by Bill 11 is that it introduces the corrosive system of dual practice. And the regulations are not going to fix that. At most, what they will do is carve out some areas of medical practice, such as emergency room services, which won't be subject to dual practice. But the two-tier system created by Bill 11 will still apply to all other forms of medical services, with resulting negative outcomes for Albertans who rely on the public health system. And that is a violation of the Canada Health Act and sets a very dangerous precedent across the country. Thank you.
Hello, everyone. My name is Chris Gallaway. I'm the Executive Director of Friends of Medicare in Alberta. And just before I talk about the Canada Health Act and the legal opinion we just heard about, I want to acknowledge that today is May 5th. It's Red Dress Day. It's an important day for awareness and action on missing and murdered Indigenous women, girls, and Two-Spirit people. And we need to remember the need for action on the 231 calls for justice, 9 of which are relevant to healthcare, and that our federal and provincial health ministers need to take those calls seriously, because we can't be here talking about public health care for all if we don't address the racism and harm those systems have caused. But specific to the Canada Health Act and the legal opinion we just heard about, Friends of Medicare is back in Ottawa today to call on our federal health minister to do her job and to show leadership on public health care in Canada. Specifically, we are asking the federal minister first to explicitly and clearly say publicly that Bill 11 is a violation of the Canada Health Act and should not be allowed to operate in Alberta. And second, for her to take actions to enforce the Canada Health Act and ensure this doesn't get put in place in Alberta in the first place. What we've heard today from the legal opinion that's being released echoes what we've heard for months from experts who've been raising the alarm, saying there is no way for Bill 11 to meet the needs of the Canada Health Act and our single-payer public healthcare system. It shouldn't be allowed to proceed. So what we're saying to the minister is no more delays, no more stalling, no more talking about looking at regulations and implementation. We need you to do your job and show leadership. Leadership the federal government has historically shown when it comes to fighting for public health care. We've seen in the Canby case that was mentioned a very clear stance in support of the Canada Health Act and our public health care system. For Albertans, we know that our provincial government right now is full steam ahead on dismantling public health care and on putting in a two-tier American-style healthcare system. We need our federal government to take their role and their partnership in Medicare seriously. It's a partnership between federal and provincial governments. We need them to act. And it's not an exaggeration to say that Alberta's full steam ahead. We actually have another Health Statutes Amendment Act before the legislature this week to expand this two-tier model to diagnostics. At every turn, our provincial government in Alberta is thumbing their nose at the Canada Health Act and putting insurance companies and for-profit healthcare ahead of patients, Albertans, and our public healthcare system. So we're here in Ottawa to tell our federal government they need to take this seriously. Our Prime Minister, who talks about nation-building projects, needs to recognize that our public healthcare is a nation-building project, that it needs to be protected from insurance companies in our ongoing trade negotiations, and we need our federal health minister to be true to her words. She says she is the guardian of the Canada Health Act. This is her opportunity and her moment to show Canadians and Albertans that that is true. Thank you.
Thank you, Chris.
Hello, everyone. My name is Dr. Melanie Bechard, and I'm the current chair of a group called Canadian Doctors for Medicare. I also work full-time as a pediatric emergency physician here in Ottawa, and I am all too aware of the many issues that our health system is facing, including long wait times. What I'm here to do is to reiterate that the proposal put forward from Alberta and the Health Statutes Amendment Act will not help to solve the problems in our healthcare system and likely will make a lot of it worse. Doctors do not want this. Dual practice, as my colleagues have alluded to, essentially allows physicians to simultaneously bill the public system for care while also charging other patients privately for faster care. This does not add new resources to the system. It does not add new doctors, nurses, or other healthcare providers. By and large, we are the bottlenecks to the wait times and issues we're seeing in the healthcare system. Rather than shortening the wait list, dual practice rearranges it so that those who have more funds go on top. As a Canadian physician, I do not want to work in a healthcare system where I'm treating some children who are going to have to wait longer for care simply because they don't have as much money as others. We know that when similar initiatives were implemented in other countries like Australia, wait times did not reduce when a two-tiered private system was implemented. This is because a few patients could pay for faster care, but the vast majority of patients relied on the public system, which had longer wait times. Again, we only have a limited number of physicians with a limited number of working hours. If we're going to be prioritizing caring for patients who can pay privately, that means that the majority of patients who rely on the public system will have to wait longer. I'm very concerned about what this could mean for private insurance companies, especially those that are based just south of the border of us in the United States, and how they could potentially create a foothold into Canada. As a physician working in Canada, I am very grateful that I have never had to get on the phone with a private insurance company and argue for medically necessary care. And I worry that as we see more private pay options in healthcare and legislation in support of a two-tiered system, that is a reality Canadian physicians will face. And I worry tremendously that not only will this contribute to the burnout that we see in the medical profession, but also long wait times. I am not here to defend the status quo. Again, I recognize that the wait times in our healthcare system can be so challenging for so many of us, and that there is a great deal of change that needs to happen. But again, asking people to pay for care is like trying to put out a fire with gasoline. There are more evidence-based solutions that we know will have a better impact on improving wait times. Investing in family healthcare teams, ensuring that every patient has access to a family doctor, would be a tremendous boon for our healthcare system. We could organize a referral system better through centralized intake systems. This is an evidence-based way that has been proven around the world in a multitude of studies to significantly reduce healthcare wait times. There are a number of things that we could be doing, and frankly, I am so disappointed to see this distraction of private pay coming up as a possible solution to healthcare wait times and issues in healthcare, when those of us working in the system know that it will only exacerbate the inequities that exist and worsen wait times for the vast majority of patients.
Thank you to all our speakers. I wonder if there are any questions in the gallery.
Sure, Raheem Mohammed from the National Post. So as you all may have seen, last week we had an exclusive with Federal Health Minister Marjorie Michel. She'd communicated that she'd had a call in late April or mid-April with their provincial counterpart in Alberta, Adrienne Lagrange, and Minister Lagrange told her that the regulations of Bill 11 would be within the Canada Health Act. Is that something that's even theoretically possible given the parameters of the bill itself?
Perhaps, Emma, you'd like to take a run at that?
Yeah, I'd be happy to answer that. I did see the article that you're referring to and the quotes from the provincial minister. No, the answer is no. Unless the regulations are going to, in effect, completely undo the structure of Bill 11, which allows for these flexibly participating physicians to simultaneously participate in both the public and private system, the corrosive effect of Bill 11 will take place. So the regulations, they might limit the application, as I said, to certain medical services. I think she's referenced emergency services and cancer care. There are some limited safeguards that the government is talking about putting in place to withdraw approval for a particular individual physician to no longer be allowed to participate in the flexible physician category if they've engaged in unethical behavior. But the fundamental crux of the problem creating the two-tier system is this rearrangement of the categories of physicians that Bill 11 puts in place. So the regulations will have no effect in mitigating the basic problem created by Bill 11.
Do you want to add anything?
Sure. I think the talk of regulations is a distraction. Even in question period in Alberta yesterday, our provincial health minister, alluded to the story in the National Post and the phone call saying, oh, the minister wasn't that concerned. They know we take the Canada Health Act seriously. And to us, this is a distraction. They're trying to move quickly, get the regulations and plan in place. And once it's in place, it's very hard to undo, especially if we allow insurance companies from the US or elsewhere into Alberta to insure these products. We might be stuck with them. So what we need is federal leadership right now who says publicly that this is a violation, Bill 11 shouldn't be allowed to happen, and prevents it from getting in place in the first place, rather than using regulations as an excuse to delay action.
So kind of understanding that none of us here are physically in Minister Michel's head, is this something she should have known, kind of heading into the phone call? Is this something that you feel like is being misrepresented both federally and provincially in Alberta? What explains that kind of miscommunication where I'm speaking with a federal health minister and she said, was communicated to her that these regulations would be within the Canada Health Act, when you're telling me that's not even theoretically possible given the parameters of the bill. So what kind of explains that disconnect?
I could speak to the disconnect. Last week, I met with officials at a minister's office. And in speaking with them, what I'm gathering is the federal government is ready to take on this fight if they have to take on a fight. But this is the problem. There has been promises made to the federal minister by the Alberta minister, promises that we don't believe can be upheld. So this turns into a little political jousting game that is being perpetuated by Alberta. And I don't believe the federal government wants to engage into a fight with Alberta. However, it seems like it's inevitable that this is going to happen, and it's going to be over healthcare. And this is very frustrating because there's a lot of people's health that will be at risk. And a lot of Canadians will be put at risk as well, because we do have other governments that are watching this and they want to implement this two-tiered system. So this boils down to politics in between Alberta and the national government. And this actually needs to come to a head sooner than later. And Ottawa needs to make a stand and say that this is a violation of the Canada Health Act.
So if you'll bear with me, there's a lot going on in Alberta right now with healthcare. And you mentioned Bill 29 for the private diagnostics. One thing that hasn't come up yet is, as I'm sure you're all aware, there are going to be a series of immigration-related questions that we put to a referendum to Albertans in October. One of those questions surrounds user fees for healthcare for, I believe, non-permanent temporary residents in Alberta. Is that something that would have any Canada Health Act implications that you can foresee and see, and will you be speaking to that referendum question?
Perhaps Emma also would like to address that, but
Sure.
Christopher.
Yeah, we think the referendums are wholesale a distraction from the government's record on healthcare. They're trying to scapegoat certain people for the issues they've created in the system, where we've had population booms and haven't expanded capacity in our healthcare system and so on. So it's frustrating to watch it play out. It's really just a distraction move that's going to take up a lot of space, and the government is spending a lot of money on these referendums. But the idea of user fees is something they've been implementing for the last few years on different issues. They've delisted services. They added fees for our vaccines, for eye exams, and so on, normalizing this idea that you pay to get access to care. So it's part of a wider strategy. The same as funding the private surgical centers in Alberta, building up that market to make it very easy for this two-tier system to be put in place. They already exist. People are getting used to paying. You flip the switch with Bill 11, and now you have a two-tier system. So it's all part of a bigger strategy. And specific to the referendums, it's absolutely a distraction. And then to your question about the federal minister's thinking, it would really help Canadians know what her thinking is if she would say it out loud. You know, she has said she's the guardian of the Canada Health Act over and over in response to questions. She has not told Canadians what she thinks about the act, what her plan is, what regulations would suit her needs and what wouldn't. She hasn't communicated publicly on this issue. So that would really help us know what her thinking is and how we could move forward on regulations and what's happening. But she hasn't shared that as our federal health minister.
Did you want to say anything, Jason or Emma, to that question?
No, I think that was a very comprehensive and complete answer.
Okay. Any other questions?
Got a few more. Two more. There's just so much going on in Alberta with healthcare and so many different angles. So kind of during the run-up to Bill 11, we still have this kind of U.S.-style healthcare kind of perception, but a few European models were quite prominent in discussion. So there was a lot of discussion about the model in the Netherlands, the model in Switzerland, both of which have private procedures, both of which have shorter wait times by many metrics than Canada. Is there space within the Canada Health Act to move toward the models of some of the better performing healthcare systems within Europe?
Let Melanie take a run at that, and then perhaps
Absolutely.
Emma and Jason.
So I'd love to address the question regarding the high-performing Western countries that we often see in Europe that tend to have some better outcomes than Canada. And a lot of the time people assume it's because they have a private two-tiered pathway. But I actually think that is a bit of a deterrent and a detriment in their systems. What we do notice when we compare Canada to other European countries, like the Netherlands, like the UK, there is a much larger proportion of healthcare spending from public sources. Those systems are much more complete in what they cover for healthcare. They have universal pharmacare systems as well, too. A number of gaps in our system are filled in those other countries. A lot of the time there is better healthcare spending and more organized healthcare spending as well, too. So when we really compare ourselves to these other nations, the two-tiered nature of the system isn't necessarily what's giving them the better outcomes. It's frankly better funding, better coverage. And if we take that model and apply it to Canada, because as of right now, Canada is the only high-income country with a universal healthcare system, but not a universal pharmacare system, then I think we will inch towards those better outcomes. But if we're asking people to pay privately for care, again, the evidence shows that that will not reduce wait times, and we will find ourselves in the same situation, if not worse. We also have to keep in mind, too, that culturally and geographically, we are very close to the United States. I think we are a prime market for American insurance companies to take a foothold here in Canada, and that is what also worries me, that if we introduce this two-tiered system, we will move towards more of a United States model than a European model. I also am concerned, too, that even though we would have a Medicare coverage for those who are not able to pay privately, there's no way to introduce this two-tiered private pay pathway without fundamentally taking resources away from the public healthcare system, because it is that zero-sum game when it comes to the number of healthcare providers we have. So that's why this concerns me, and I worry that it will not bring us closer to what they have in the Netherlands, but closer to what they have south of the border.
Anybody else want to say anything about that?
I mean, I can just add that, as you know, I think the Canada Health Act premises the federal transfer of payments to provinces on 5 key principles. And the most important for the purposes of what we're talking about today are universality and accessibility. And that means that all those who are insured within the system have to have access to the same medically necessary services on the same uniform terms and without any financial barriers. And I mean, under the Canada Health Act, there isn't an absolute prohibition against private care, as you know, but the compromise that has always been struck in various provinces, with the exception of Ontario, which doesn't allow it, is that you can have physicians who are unenrolled from the public system and can work for private pay for service, but they can't at the same time also be paid through the public system for the same services. And the problem with what Alberta is introducing, and which it completely defies these key principles of universality and accessibility, is it's going to allow physicians to straddle both systems. And there's just an inbuilt conflict of interest, which incentivizes then our very limited resources to shift into the private system. So, there is no way within the framework of the Canada Health Act to allow for that kind of two-tier system without completely corroding those key principles and the promise and commitment of the Canada Health Act.
Did you say you had another question?
Yeah, just one last one, and then we'll wrap it up. So you did mention sort of other kind of more ideological provincial premiers. You mentioned Doug Ford, Francois Legault, I guess, Christine Frechette now in Quebec. One person you didn't mention is the Liberal Premier of New Brunswick, Susan Holt. So sort of my understanding of what we've seen in New Brunswick is Premier Holt has continued on with the prior progressive conservative government's move to carving out more of a space for private clinics. And like granted, New Brunswick started from a very, very low bar when it came to wait times. I think they were the worst in the country. But you have by some metrics seen an improvement in that respect. So is there anything fundamentally different that we're seeing from Premier Holt in New Brunswick versus some of these other premiers that might be taking a more ideological tact to eroding public health care?
Did you want to take that, Emma?
I can speak to it a little bit as well, too.
I think this might be a better question for the Canadian Doctors for Medicare, actually.
Right, I think you're right.
Yeah.
But we did, in the legal opinion, we did include Quebec and New Brunswick we sort of addressed some of what you're raising, but go ahead, Melanie.
Yeah, I think part of the issue is that when we talk about privatization, it really is quite a blanket term. And right now in Alberta, we're talking about private financing, so having people pay out of pocket for care. I'm not as much of an expert in New Brunswick, but I work in Ontario, and over the past few years, we've seen a big push towards more private delivery of healthcare. Frankly, a lot of healthcare is already delivered privately in Ontario. I work at a hospital that is not a government institution. I'm not a government employee. Technically, that is private delivery of healthcare, but it is private nonprofit. And what we've seen more frequently in the past few years in Ontario is a move towards private for-profit delivery, particularly for-profit delivery that is investor-owned, so that there's shareholders involved. And we do see that there are some risks with this move towards private delivery. When we look at, for example, long-term care facilities during the pandemic, those that had private for-profit delivery had worse COVID-19 outbreaks, higher rates of mortality. We tend to see, even in BC, when this has been studied, that private for-profit clinics will deliver similar care, but tend to have a higher risk of worse patient outcomes and at a higher level of cost for the government. So there is that public financing going towards private delivery. So this is very different compared to what we've been seeing in Ontario in the past few years. By and large, we've seen respect from the other provinces towards not charging patients privately and staying away from that private financing of care, even as we've seen a move towards more private delivery. So what's been announced in Alberta is a complete paradigm shift. This is blatant private financing of healthcare and is very different from what we've seen in other provinces.
So just help me understand, like
Yeah,
a private,
yeah.
nonprofit paradigm of care would be like your Jewish hospital or your Catholic hospital in Toronto. What is that?
Pretty much any Ontario hospital. This is different for different provinces. Some provinces, the hospitals are run under provincial health authority, so there is some public administration and delivery of care there. But in Ontario, the vast majority of hospitals, pretty much all the hospitals that you'll see down the road here in Ottawa, are private nonprofit institutions, just because we're not directly run by the government. And that's pretty common. That tends to be a standard way of delivering care in Canada and not as concerning to us. So we always encourage at Canadian Doctors for Medicare, when we discuss privatization, to make that clear distinction between whether or not it's private financing or private delivery, because they have very different implications for access to care and patient outcomes.
Okay. So,
All right, thank you. This concludes the press conference. Ceci met fin à la conférence de presse. Merci beaucoup. Thank you very much.
Thank you.
thank you.